Thank you to our both international experts. Now we will take questions. Before that, we will call Dr. Ward, Dr. Kirby to join us on the panel. Now, we have 2 microphones in the back. Questions can be written and myself or somebody else can read them for you. We could also take questions from the floor. Now, we have Doreen, who will also help you with the questions, and she will moderate the questions. So, who's going to start?
So I've got the microphone here for those of you who chooses to ask questions. I'll come over so you can be heard by everyone. Great presentation, great information. I'm sure you were well fed with the knowledge tonight, so this is your opportunity. Please utilize it.
Thank you all various speakers, and I'm delighted this evening really to see in our presence Madam Jean Augustine, who has been up and doing, trying to promote every little thing she lays hands on. She has helped Africa, Kosovo, Sri Lanka. I know we're not going to let you go free. You will stay with us. I know what you are capable of doing. My question is, how come the inconsistency in sickle cell behavior? A parent or parents can be carriers, but their products sometimes, some will have sickle cell and others don't. You will have a family of 4 children. 2 may have it, then the 2 don't have. Why is that inconsistency?
So, for every, both parents are carriers, and for every, so what each parent carries 1 gene that's normal and 1 gene that's a carrier for sickle cell or thalassemia. Every pregnancy is treated as the same. So every pregnancy, there's a 1 in 4 chance of having a baby with sickle cell if they're both sickle cell carriers. And then next pregnancy is the same 1 in 4 chance. So it's like flipping a coin, 2 coins, which coins drop on the sickle for the baby, a sickle cell carrier, the sickle cell gene and the sickle cell gene. That baby would be affected. Or maybe the next pregnancy, a sickle cell gene would fall and a non-sickle cell gene would fall, and that baby would be a carrier. And the next pregnancy is the same chance. So we have families with 7 kids and 1 sickle cell patient. We have families of 4 with 4 sickle cell patients. So it's by chance, and every pregnancy is the same chance. I wish I could do a little drawing to show you. So on the first pregnancy, you might have both sickle and sickle gene, and you have a baby with sickle cell. And every pregnancy is the same. Or you could have the mother giving the normal gene and the father giving a normal gene, in which case you have a totally normal, a baby with normal hemoglobin. Or you might have the father giving, or the mother giving a sickle, and the father giving a normal gene, and you have a carrier, like the parents. So every pregnancy, it's a 1 in 4 chance of having a baby with sickle cell, a 2 in 4 chance of having a carrier baby, and a 1 in 4 chance of having a baby who has neither sickle cell, has totally normal genes. And every pregnancy is the same thing. So because you have, sometimes the first pregnancy you have this baby, the next pregnancy you could have, all the pregnancies could be the same baby. Every pregnancy is the same chance. Is that clear, sir?
Yes, what progress?
Pardon me?
What progress is clear.
Okay.
That is, the chances are 50-50.
Well,
That's what I'm like.
so every pregnancy is 1 in 4 chance. 25%.
Okay, I've got another one.
And just, if I could say this, sometimes when you go to your doctor, you get asked, what are the chances? And say, oh, it's just a small chance, 25% or a quarter chance of having a baby with sickle cell. If it was so, it is a 1 in 4 chance, but we have a clinic with lots and lots of children and adults. So that 1 in 4 chance comes up more often probably than, well, I wouldn't say more often. The chance is equal, a 1 in 4 chance across the board. Okay?
Okay.
Thank you.
If you're not clear, we have it on our pamphlets for the Thalassemia Foundation. They're in the back of the room or in the front. Also, if you visit the websites, it will be there, just for clarifications. Now, the next question, I have a question from a parent of a thalassemia patient, and I believe this is for Dr. Ratna Chatterjee. The question is, when it comes to prevent or treat osteoporosis, osteopenia in thal major patients, is there a better chelation therapy, i.e. Desferal, Deferricone, XJ, or combination? Follow-up question, can you comment on the impact of iron chelators on osteoporosis, osteopenia for thal major patients?
I think the first and foremost thing I would like to say is that in the list of factors which are causing osteoporosis, it's mainly iron overload, and iron overload. That's the first thing. So it doesn't matter what chelator you use to control the iron overload, that should be done. So please don't stop taking chelator. That's the first point. The next thing is desferrioxamine better than XZ or XZ better than L1 and so on? Now, I think the care of the patient or the chelator has to be individualized according to the patient's needs. And firstly, it is very important for you to appreciate that desferrioxamine given in judicious doses can certainly take not just iron out of the body, but calcium and other minerals which are very important for growth. Now, equally, desferrioxamine can cause various types of bone toxicities. For instance, it can cause ricket-like picture, pseudo-rickets, skeletal dysplasia, and so on. So if you wanted to say that is desferrioxamine a very dangerous drug for the bones, the answer is no. We have over 30 years of experience with desferrioxamine, and it's very important for you to understand that in many countries, people are not using desferrioxamine, but using L1 or